Welcome back, everyone, to a brand new episode of the Preventive Medicine Podcast. I'm your host, Dr. Raghav Sharma. We have another incredible guest on today. We've just had incredible guest after incredible guest on. I'm excited to get into this one. So this one is Dr. Shounuck Patel. He's actually a fellow CCOM alum, so Chicago College of Osteopathic Medicine, went to the same school. He's doing stuff very similar to what I want to be doing in the future as far as interventional spine, musculoskeletal medicine, being a master diagnostician of kind of whatever's going on within the body. He did his training at the world-renowned OSS Fellowship. He's a master instructor for the Interventional Orthobiologics Foundation. I tripped over orthobiologics so many times in prepping for this. I still do. He's an internationally renowned speaker for both ultrasound education and for orthobiologics. He's the associate clinical professor at two medical schools in the Southern California region, and he is currently the founder of the Patel Center for Functional Regeneration in Newport Beach. And I can say I've been with him for a morning there, and he absolutely loves to teach. So if you want to learn more about some of this stuff, he has great content on his Instagram and YouTube. I'll link it in the show notes below. It's at Regen Dr. Patel. But Dr. Patel, welcome to the show.
Thank you very much. It is an absolute pleasure, and I appreciate you inviting me on. This is exciting. I'm always excited to teach, and you've been such a fantastic person that over the past couple of years known you. Excited to see what you do in the future, but happy to be here.
Definitely. All right, let's get into it.
Overcoming saber-toothed tigers and woolly mammoths, we must now face a new enemy, ourselves. With the rates of diseases such as heart disease, stroke, diabetes, depression, and many others ballooning, we must find a better solution to these modern epidemics. Welcome to the Preventive Medicine Podcast. We believe in building a foundation of health by means of prevention so that you can build the life you want and find fulfillment with no barriers. Hear from experts around the country on how to take your health into your hands. Take control and build a foundation of health for the life that you want to live. And now, here's the show.
All right, let's get into this podcast. We are talking about orthobiologics today. Before we get into anything, Dr. Patel, what are orthobiologics?
Great question. Orthobiologics. We used to think of it as purely things like stem cells and PRP. Orthobiologics refer to different things that are injected to stimulate some level of a healing cascade in our body. And that can range from some things like prolotherapy or dextrose sugar water injections that have a history of several decades old in terms of research, all the way through to what's become very popular right now as such as platelet-rich plasma. So all of these kind of fall under the umbrella of orthobiologics.
So as we come to orthobiologics, we think of stem cells. So those can have kind of healing properties, as well as some people think them as preventively. Before we get any further about that, the number one question I like to ask my guests is, because this is the Preventive Medicine Podcast, is what does preventive medicine mean to you?
Preventive medicine.
You can say it both ways. I argued over which way to say that for so long, and also in the title of the podcast, I was kind of stuck.
It's a debate.
It's much shorter.
It's a debate in and of itself. But ultimately, what that means to me is we think a lot about medicine and adding years to our lives, but I think of it as adding lives to our years, or adding life to our years. And that's really what it comes down to. How do we prevent things from getting worse? There are things that unfortunately are degenerative by nature, but how can we best optimize our lives moving forward as we age? And that's what I think of it as.
Definitely. So as far as where that takes you from adding life to our years, where does that leave you as far as what kind of stuff are we adding? And are we adding in like injury-free stuff? What are we adding in here?
Well, point blank, it's impossible to not have pain throughout your life. It's impossible to not have an injury in one way, shape, or form. You can argue if you're completely sedentary, well, you're going to prevent yourself from having specific musculoskeletal injuries, sure. But then you're going to have a slew of other issues that you're going to have as well. So, ultimately, I think it's a matter of how do we live our lives the way that we want to live it to the best of our ability, and in as much of an injury-free way as possible.
I love that you mentioned that, because oftentimes I think a recurring theme on this podcast is not that we're just trying to prevent things outright and not even take risks, but it's about mitigating risks so that we can still live the life that you want, and just kind of focus on doing what you can in your control to kind of minimize the risk of injuries.
Yeah,
So
that's exactly right.
as far as regenerative medicine, what role does that play in there? Is that something that's used preventively, or is that only used as a treatment? Because usually when people think about it, and usually when that comes up in context, it'll be like, for example, I'm in a patient room and a patient has knee pain, and we're talking about options to treat that. We've gone down the route of injections, and PRP comes up. Is that the only context in which orthobiologics are discussed?
Yeah, I think that's a very common context that orthobiologics are discussed is in the treatment of situations. Well, the realistic thing that we have to recognize is that orthobiologics are not just an alternative for a corticosteroid injection, and I think that that's the common misconception that we see, is that if somebody has an injury or a pain condition, um, how do we treat that pain? How do we provide some pain relief? And when we talk about pain management, well, that's where things like corticosteroid injections, radiofrequency ablation, and things along those lines, those things benefit by reducing pain. But the way in which orthobiologics work is certainly by improving or modulating pain, by improving or modulating inflammation, but also there is the real potential of structural changes, of improvement of tissue, and the real possibility of slowing down or preventing the progress of degenerative disease.
Yeah, so this isn't something that's necessarily used for what we would call primary prevention, as in someone's not going to come into the clinic and be like, hey, inject all of my joints. I want to prevent any sort of damage to them. Is that correct?
Well, I mean, people will come into the office asking for that. Now, I don't think we're at that level that it's ethical, in my opinion, to do something like that if somebody has zero pain. But we also have to think about what does pain mean. So, for example, I'm working with some physical therapists that are involved with the NFL and the combine and all that, and working with some agencies that are investing X amount of money into their athletes. And we see, especially recently, within the last couple of years, we see how many different repetitive hamstring strains, we see how many different Achilles tear that are occurring without any specific traumas that are causing it. And we recognize that a lot of this is overuse, a lot of this is over specialization from an early age, but all of it is also associated with ignoring certain signs. So that no pain, no gain Mamba mentality may also be detrimental to a certain regards if we're not paying attention to the subtle signs that things are going on. So we're going to be looking at things like imaging studies, ultrasound, physical examination, etc., to see if we can catch subtle signs of things that are going on before they become more prevalent. And if we have some subtle symptoms associated with those subtle signs, the advantages of things like orthobiologics is that we don't have the negative side effects associated with the corticosteroids do. So potentially using certain orthobiologics in somewhat of a preventative manner is something that we're looking into actively right now.
A couple things to point off of that. Number one, this poster, if you're watching YouTube, literally right here is a Mama Mentality poster. You can't see it on this camera, but right here it says Mama Mentality. Secondly, you mentioned athletes in there, and I think you mentioned the use case of prevention for athletes as far as this little like niggles or whatever you want to call them, and like an Achilles that you might find in ultrasound that are not really symptomatic, quote unquote. But what about the regular person as far as like, is this something that can be used for, let's say, I'm not an elite athlete. Could this be useful for me for if like I'm out trail running, I want to prevent my knee from getting worse?
In theory, potentially. Practically, I tell my patients all the time, I'm not going to be sticking a needle in you if you have zero symptoms associated with it. Because we all know the literature that shows that, you know what, you scan X amount of MRIs of X amount of body parts, you're going to find something, right? And realistically, that is very, very true. Some of those things are completely normal things that happen as we get older, right? Having a disc degeneration is like saying you got wrinkles, right? So there's always going to be things that we see on imaging. So that being said, if there are things that we see on imaging that correlate with some signs or symptoms, either subjectively or objectively on physical exam, well, those are the type of scenarios that we may want to pay attention to. And a perfect example of this, and this is something that comes up in my clinic all the time, is like, oh, I've had my back go out before. And every couple of years I'm deadlifting and all of a sudden my back spasms for a week. It calms down and I'm perfectly fine, right? All right, it was just a pulled muscle, not a big deal. But is it, right? And what I see very frequently is these patients coming back to me X amount of time later with now knee pain, with now this, with that, with now that. So we have to take a step back and look at that a little bit more in depth. If somebody's having their back go out, your back muscles, your paraspinals are strong things that aren't going to be tearing with just little activities. But what commonly happens is an annular tear in the disc. And if that annular tear calms down, it's not inflamed anymore, it could still be causing some chemical irritation periodically. And if we don't do a thorough physical exam and see, all right, they have some dural tension, they have proximal distal L5S1 weakness, they have these patterns that something is going on, well, now we're going to have patellofemoral maltracking because the butt muscles aren't firing properly, right? Or now we're going to have a hip issue because of the asymmetries of muscles. So if we start paying attention, rather than saying, all right, no pain, no gain, if we start paying attention and if we're seeing little patterns of stuff that are going on, even if we're not in active symptoms at that juncture, that may be an area for us to be able to intervene sooner than later.
Definitely. So I want to dive into your mentality a little bit there as far as that treatment approach. So I think as far as like most commonly musculoskeletal medicine type stuff, if someone keeps coming in every like 3 to 4 years, not really a big deal. You're not going to be thinking about these little annular tears that you might be able to treat or do something about. How did you come to start thinking about those little things and those little details that you can maybe try and prevent something else in the future?
Yeah, that's a good question. And realistically, you're right. When the people come to our clinics saying, "Hey, I have this little things here and there," we're not thinking like this because we're trained to think reactively. We're trained to think. Our tools in our tool belt include things like epidural steroid injections, but we're not going to do an epidural steroid injection if you're not in significant pain, right? That's morally and ethically immoral, right? That's not appropriate because corticosteroids have significant side effects associated with them. But the way that I came across this was partially because of the people that I trained under. Respect to a lot of the forefathers of orthobiologics that I had an opportunity to train under, such as the late Jerry Malanga, such as people like Chris Centeno and others, that I got to understand that we have to look at the whole picture. And by looking at the whole picture, we can recognize patterns of things that are going on. Too many times I started seeing patients that came to me with a knee condition that, just happened to happen without any specific injury that caused it. But then why, right? Taking a step back and looking at it, there was X, Y, and Z other things that were a part of the picture that painted the story over the course of their lives. Um, you know, Plantar fascia tear unilaterally, attributed to just wearing heels. Well, you're only wearing heels on one side, right? What caused that to occur? Upper limb issues, lateral epicondylosis in the absence of specific injuries, things, right? We have to start thinking about the why. And that's what caused me to start looking at, what can we actually try to be proactive about?
Definitely. I want to put myself in a patient's shoes for just a second here. You mentioned one of the reasons that you're using and thinking proactively is the use of orthobiologics and potentially like make things better and make sure that they don't happen in the future or again. But you mentioned in there that corticosteroids have significant side effects. And I'm thinking if I'm a patient, I'm going in to see not yourself, but anyone else. Usually in the toolkit, there are mostly things with corticosteroids. Usually people are not talking about orthobiologics. Is there a risk to those as far as like preventive medicine wise? Because we're thinking we want to prevent things. If a patient gets a corticosteroid injection, are they risking future injury? Is that what you're saying here?
Depending on the situation. So corticosteroid injections, I don't want to say that I'm demonizing them entirely. Maybe NSAIDs, but not corticosteroids. No. We'll get to NSAIDs in a second. But corticosteroids, there is a time and place for everything, period. Corticosteroid injections, the most literature in support of it, let's say for low back, and a radiculopathy, is if you're a young single level radiculopathy with a single level disc protrusion that is more acute, then yeah, there's a very reasonable time and place to do a corticosteroid injection. However, as time goes on, and if you've done 2, 3, 4 epidural steroid injections over time, and we're getting more and more limited benefit, you have to recognize that it has its limitations. Now, as we get older, corticosteroid injections have been demonstrated to increase, osteoporosis and fracture in osteoporotic patients, and have effects of increasing blood pressure and increasing blood sugar. So we have to start recognizing that repetitive injections of corticosteroids is really where the downside is. And even with several years ago research that has been repetitively showing that repeated corticosteroid injections into the knees can increase cartilage damage and increase degeneration. There are real side effects associated with it. Now, a single corticosteroid injection in somebody that has a hot joint or a hot radiculopathy that would otherwise the pain is getting in the way of their exercise and their movement, well, yeah, that's a very reasonable strategy to use a steroid injection.
Yeah, I think I align with you really well there, because the use of those corticosteroids for, you're not necessarily preventing anything, but you're treating that pain. But by treating that pain, you're allowing the patient to re-engage in their exercise program, re-engage in the activities that they like doing, maybe re-engage and hang out with their friends that they weren't able to do before. And then all of a sudden that provides all of those tenets of preventive medicine that we talk about so much on this podcast. And that's kind of where that comes in.
And on that note, like, the way that I use corticosteroids now, it's sparingly, admittedly. However, the way that I'll use it is to allow a patient to then do X, Y, and Z. Whether it's, I need to get through my daughter's wedding this weekend, or whether it's, the pain is getting in the way of me actually firing my muscles in physical therapy, let's do that. Now, we have to also be very, very diligent on explaining to patients that, look, you're going to get pain free, but that doesn't mean we're not doing anything for yourself. You have to then follow up with the appropriate exercise, the nutrition, getting the body moving correctly, connecting all those dots. If you're just going to do the corticosteroid injection, again, then you're going to fall into that pattern of injections every 3 to 4 months.
Exactly. 100% agree with you there. You mentioned NSAIDs and that you were jokingly demonizing them. What's going on with that?
NSAIDs, it is a very interesting category of medication that I think, again, has its time and place. I think it could be a very applicable medication for autoimmune pro-inflammatory conditions. However, it's one of those things that's popped like candy. And since it's over the counter, a lot of people don't even think of them as medications. And it's honestly just overused across the board. There are slews of side effects associated with it, everywhere from GI to cardiovascular, right? But what we don't oftentimes think about in mainstream medicine is the negative effects that NSAIDs have on healing. And there's ample evidence at this juncture that suggests that it could interfere with healing, and not only just healing in general by being anti-inflammatory, but also potentially even with things like collagen synthesis. So we have to recognize that there's probably more negatives than positives when it comes to NSAIDs for most applications. Now, again, certain situations notwithstanding.
Sure. So we've mentioned kind of corticosteroids here. We mentioned NSAIDs, and obviously you use a fair amount of orthobiologics. What does your day-to-day look like? Are you just using like PRP as an orthobiologic? First off, I guess, can you explain what PRP is, and then kind of where these orthobiologics come from? Are we just like buying them from somewhere, or where are they coming from?
Great question. So, the treatments that I do in my office are all almost all autologous, coming from a patient's own body. I will use dextrose prolotherapy, which I could explain briefly as well, which is a concentration of sugar water. And other than that, I'll use a patient's own blood growth factors, PRP, and a few different variations of that. I'll use a patient's own bone marrow or bone marrow aspirate concentrate, BMAC, which contains stem cells, but also contains a slew of other things, including growth factors, platelets, and anti-inflammatory proteins. And then I'll use a patient's own fat, which what we create is called microfragmented adipose tissue, which is basically a tissue transfer or a graft that we use. Also contains living stem cells, however, is used for more structural support for patients. Now, these things work in different ways across the board. The dextrose prolotherapy, the sugar water, the way that it works and the way I explain it to patients is that sugar water actually causes a little bit of irritation at the structures where it's injected. That irritation causes a little microscopic apoptosis or small cell death, tricks the body into thinking that there's a new injury there, and then the body sends its blood growth factors to start the healing cascade. And there's evidence that suggests that the healing cascade is propagated by this, and it's used really well for milder conditions as well as conditions where there's injury to vascular structures like ligaments. Up the chain from that, I use platelet-rich plasma. Now, the dextrose, the sugar water prolotherapy, tricks the body. The body sends over its blood platelets, and that's what starts the cascade. So platelets, when you cut yourself, the platelets are the thing that stops the bleeding, right? And then the platelets, after they form a clot, slowly release these growth factors that cause inflammation and then take inflammation away. And again, propagates the healing process. Part of that inflammation, calling over macrophages to get rid of the damaged tissue, calling over your local stem cells, because we have stem cells throughout our body, and the stem cells are the general contractors of the construction site. That's how healing takes place. So we could take your blood and make a high concentration of those blood platelets. That's called platelet-rich plasma. And basically, that is exponentially stronger than a prolotherapy. And then when we use our cell therapies like bone marrow and fat, that's ultimately going to be exponentially stronger than your PRP.
All right, so you said stem cell in there, and stem cell, unfortunately, started to get a little bit of a bad rap in places, especially kind of in the preventive medicine world, because you have these people that are biohackers that are kind of using them as kind of this panacea for trying to reverse aging, for doing all kinds of funky stuff. And there's even some of my own colleagues that like go down to these different countries like Colombia or wherever that have these stem cell clinics, and they just kind of get infusions of stem cells. Is that something that there's any merit to, or like is that just absolutely like woo woo?
There's probably somewhere in between. But until I see research that's robust enough, I fall more into the camp that thinks of it as woo woo. And look, I think that there's some people doing some legitimate things with allogeneic stem cell products, particularly outside of the country. And I'm hoping to get involved with some legitimate research in which we're using some allogeneic products outside of the country and looking at the potential benefits of these products. However, we have to recognize what these things can and cannot do so far and what the literature is and is not showing. There is a lot of promise with some of these treatments that promise starts with animal models and basic science research. However, because of that promise, there's a lot that have started making that into hype. And there's a tremendous amount of hype that's surrounding stem cell treatments and a variety of other biologic treatments in this setting of longevity. And longevity is a beautiful word, and it means a lot to a lot of different people. I have patients that and I have colleagues that are knee deep in the longevity space, and some of which is really promising, some of which seems really fantastic. However, I still am not convinced by a lot of the research that is available at this juncture. Again, there's a lot of promise, but for some of these things, until I see safety studies that say that it's all right for me to put an IV and flush your system with stem cells from another body source, I'd be concerned of negative potential side effects down the line. And personally, I'm not quite getting involved with that yet. because I don't want to be a part of a future mesothelioma ad. So that's really what it comes down to. We have to recognize that there are potential actual risks associated with these things that we want to kind of pause and take a break, despite what some celebrities may be doing.
Yeah, you're gonna end up on an ad like, "Have you or your loved one been affected by allogenic stem cells?
Yeah,
Contact blah
exactly,
blah blah blah."
exactly.
I also every time I hear the word longevity, I start kind of rolling my eyes at this time because I think it's kind of negatively co-opted what preventive medicine is supposed to be. Because it takes, like you said, a lot of this what is promising research and just kind of puts it out there as this panacea for others to spend a lot of money on at this time. And you have like mostly like wealthy people that go to do these things, and then you have regular folk or people who don't have as many resources are like, oh man, of course they have the best treatment out there. Do you think that there's close promise to this? Is this something that we're going to see like in our lifetimes as far as getting these treatments, or is this not there yet?
To a certain extent, yeah, and I think there's some things that are going in that direction. However, what do we also mean by longevity? Like, are we talking about just increasing our lifespan? Are we talking about truly preventing disease? Are we talking about, regrowing a lost limb? Or are we talking about reversing osteoarthritis? Like, what exactly are we talking about here?
Mm-hmm.
I think that very likely in our lifespan, we're going to be able to um, halt the progress of degenerative conditions such as arthritis. I think that we're going to be able to, potentially cause like some regrowth of tissues such as discs, such as, cartilage and things along those lines. I think those are very, very realistic things. Are we going to be able to, again, panacea, prevent all diseases in our lifespan? That seems a little bit more hokey to me to think about, and especially with things that we still don't know can benefit one thing, let alone all things, right? Now, IV stem cells, for example, some of it makes sense to me if you have a cardiac or pulmonary condition, right? Because when you're throwing something in your IV, the majority of those cells are going to end up in the heart and the lungs. So, even a decade ago, I had a patient with end stage CHF end up getting some crazy IV treatment somewhere out of the country, and he had a substantial improvement of his symptoms objectively. And there's something to be said about that. But anytime somebody's getting some treatment just kind of for longevity as a whole, I still don't 100% know what that means, let alone I can't, support it.
For sure. So it sounds like there's some promise for some of these treatments within the next several like years to decades, maybe, as far as improving things. Now, my biggest question, I guess my biggest gripe itself with orthobiologics is that because it's considered quote unquote experimental, it's not something that is typically going to be reimbursed by what is the healthcare system in the United States. As far as all these insurance companies, they're not paying for PRP, they're not paying for BMAC, they're not paying for any of this. So my gripe is always like, is this something that obviously I'm asking someone who does this a lot, so a little bit of a devil's advocate here, but is this something that patients should be like asking for as far as there's enough evidence to say, hey, I want PRP, I think it's going to help? Because this is something that people are putting a oftentimes pretty significant investment into these products. Do you think we're there yet at a pretty broad basis, or we wouldn't go that far yet?
For certain things, I think that we're definitely there. So, for example, I'm involved with a consensus statement that should hopefully be coming out for AAPM&R in regards to PRP for knee osteoarthritis. And there is a substantial amount of research in support of PRP for knee osteoarthritis, particularly mild to moderate knee osteoarthritis. Better than corticosteroids, better than hyaluronic acid, more research in support of it than both of those, as well as saline, as well as X, Y, and Z, right? There's evidence to suggest that it could slow down the progress of degeneration and slow down the time frame to necessity for knee replacement, right? Now there's more recent research that we're recognizing the type of PRP matters and the quantity of delivered platelets matters. So we're getting more and more nuanced into recognizing this, but the evidence is very clear for osteoarthritis of the knee. Okay, very clear. And there are some insurances that have started to cover it. So there's definitely movement in the positive direction with that. Now, There's level 1 evidence for lateral epicondyle. There's level 1 evidence for gluteus medius tendinopathy, and a variety of things have growing research in support of it. It's only a matter of time for us to recognize that this is truly a better alternative and a completely different animal than a corticosteroid injection. So I think that when it comes to things like knee osteoarthritis, 100% patients should be inquiring about it. Now, it also does matter who they're inquiring to, and to a certain extent, the knowledge base that person may have, because pretty much everybody should be able to inject inside of a knee. But depending on the condition, not all PRP is created equal, and not all ways of delivering the orthobiologic is created equal. So we also have to recognize that there are nuances that are still in that. So it's important to go to somebody that knows what they're doing.
Definitely. So I guess as far as if someone's kind of to summarize this, if a patient is thinking about orthobiologic treatment, what do you think they should start with? Let's say in general, kind of, we're talking hips, knees, shoulders. What kind of things should they be thinking about regenerative medicine for?
Well, if anyone's lucky enough to be listening to this podcast, or thinking about orthobiologics in general, thinking about preventative medicine in general, and if you're lucky enough to get in front of your knee osteoarthritis, hip osteoarthritis, whatever it may be, while things are still in that mild to moderate category, instead of, or once you've already done a corticosteroid injection and you've had only X amount of benefit for X amount of time, then that's the type of circumstance where we need to start thinking about orthobiologics and being more proactive about it. And in that setting, in that mild to moderate category, PRP could be a very reasonable approach. There was a study done for knee osteoarthritis in which PRP was pit against corticosteroid, and they were found to have equal benefit. So people in my world were saying, "Oh, another study that shows that PRP doesn't work." But in reality, that type of PRP that was used for that study was actually a very low concentration, poor quality PRP. And it had the same benefit as a corticosteroid injection
Without a lot of the downsides.
without the downsides, right? So even getting a bad PRP injection will still be potentially as good as a corticosteroid injection without the downsides. And if you get a better quality treatment, then you're expecting better and longer term results.
Yeah, on a personal level, I can say in residency, you're not exposed to orthobiologics that much, just because academic centers typically don't have that much capability or access to it, unless you're on the cutting edge of that research. But as time goes on, I'm kind of realizing more and more, even throughout fellowship, the utility of them, especially in the right patient population. I even excluded it in my main research study for residency because it was better than corticosteroid and hyaluronic acid. And I wanted to compare the treatment effects of typical injections versus patient beliefs. So if PRP if it was proven to be better, then I want to exclude it, because then patient belief is not necessarily as equivalent as the rest of them.
Yeah,
so definitely becoming more of a believer in there.
And it's changing in the academic centers too. There are more and more people doing PRP in the academic centers. So there is a shift in that direction. And particularly since the world of regenerative medicine started being recognized as an academic rank by the Mayo Clinic in 2020, there has been a shift in the positive trajectory as far as orthobiologic research in the academic settings are concerned.
Definitely. I'm really excited for orthobiologics, for regenerative medicine, and the future of it, to kind of learn more about it throughout my fellowship, which I'll be getting a lot of exposure. But Dr. Patel, the last question I have for you as we wrap things up is, if a patient comes to you, let's say you're about to leave for the day or about to leave for lunch, you have 2 minutes, they ask you, how do I get healthy? What do you tell them?
Move. Movement is key. And that could be as simple as walking. That could be simple as shadow boxing. That could be as simple as just waking up 5 minutes earlier so you can do some stretching in the morning. But depending on the scenario, movement is absolutely key. One of my mentors, Dr. Furman, said, "Motion is the lotion." And I think that's probably one of, if not the most important things that you can do for your body.
Very well said. Well, Dr. Patel, it's been an absolute honor to have you on the show. Thank you so much for coming on, and have a good rest of your day.
Thank you very much. It's been an absolute pleasure.